Hello and welcome to our third installment on the basics of hemodynamics. With this lecture here, we'll explore why we perform quantitative analysis or perform measurements to assess regurgitation over qualitative analysis, which is basically visual estimates. We'll use the stroke volume method to assess regurgitation and work through an example in a clinical setting. And the stroke volume calculations can be further derived as regurgitant fractions, which is another way to demonstrate severity. As mentioned in previous lectures, there are inherent limitations, assumptions, and potentials for error in these formulas of evaluation, which we'll actually expand upon further. Evaluation of regurgitating valves is important in echoes. We wish to investigate the severity beyond the basic visual assessment with color Doppler. The laser sonographer will only use this for the determination of regurgitant lesion severity. In doing so, there are problems which lay in significant interoperative variability. One person coming in and viewing what appears to be mild mitral regurgitation may appear to be moderate to another sonographer. It's also not easy to distinguish the differences associated with mild changes in regurgitation. A small step up from mild to moderate may actually appear very minimal. When an observation is quantified, we can easily place the findings on a scale. We have definitive borders of what mild, moderate, and severe are. And multiple forms of analysis help guide the sonographer to actually assess the severity and accurately determine it. So we steer away from the sole qualitative analysis and turn to quantitative analysis to effectively assess valve lesions and whether they be stenotic or regurgitating. Our flow calculations revolve around the simple principle of conservation of mass. Simply put, we refer to what goes in must come out. As we'd expect, the stroke volume between two cardiac valves is equal in the absence of an intracardiac shunt or regurgitation. In regurgitation, the stroke volume through the incompetent valve is increased. It's the sum of the normal stroke volume that moves through the valve plus the volume of the blood that has leaked backwards into the previous chamber that needs to be expelled forwards again. Writing that as a mathematical equation, we demonstrated here. Stroke volume of the regurgitated valve is equal to the stroke volume of the competent valve plus the regurgitant volume. And rearranging this equation, we can see that regurgitant volume is equal to the stroke volume of the regurgitant valve minus the stroke volume of the competent valve. Therefore, it is important that the assessment of a competent valve that is used in this equation, it must not leak. To do so will distort our calculation. Viewing the calculation above, we can see a larger competent valve VTI will lead to the regurgitant volume being reduced. A common valvular lesion is mitral regurgitation. In this instance here, we can see mitral regurgitation volume is equal to the stroke volume through the mitral valve minus the stroke volume through the LVOT. So the LVOT being a competent area, the mitral valve being the incompetent area. Expanding upon the formula further, we can see that mitral regurgitation volume is equal to the cross-sectional area, the mitral valve, times the VTI of the mitral valve, minus the cross-sectional area, the LVOT, times the VTI of the LVOT. Further drilling down, we can see that 0.785 times our diameter squared times the VTI minus 0.785 times the diameter squared times the VTI will give us our regurgitant volume. In this instance here, we assume the aortic valve to be competent. If it did leak, we could substitute for the right ventricular outflow tract, or alternatively use a non-valve location such as the main pulmonary artery or ascending aorta. Similarly, for assessing aortic regurgitation, we can calculate normal stroke volume through the mitral valve or the LVOT, or again the vessels arising from the heart. Tricuspid valve is not preferably used due to difficulty and lack of reproducibility in measuring the actual diameter accurately. This can lead to significant error into our calculations. This is an example of how a sonographer will proceed to acquire the necessary detail for the calculation. We have the mitral annulus dimension taken from the apical forechamber. A zoomed image is preferable to enhance 2D imaging and increase accuracy. Leaflet insertion point to leaflet insertion point is taken on a frame in early diastole when the valve is widely patent. This gives us the diameter which we use to determine the cross-sectional area, as we can clearly see here. Pulse wave from the same view is paced at the annulus level and spectral trace is obtained. The modal velocity is traced with the inner brighter edge. This gives us the VTI of the annulus level. So it's important that we're actually placing our sample volume at the annulus level and then tracing the VTI, the brightest inner edge, all the way through. A similar process is then applied for the LVOT. Preferably the parasternal long axis is utilized for the LVOT diameter, and again the image is zoomed. Mid-systole is the preferred frame to measure on, and again we can see the leaflets are fully opened here. From the apical 5 chamber or the apical long axis, a pulse wave Doppler sample volume is placed in the LVOT, not too close to the aortic valve to ensure we're getting away from flow acceleration, and not too far away from the valve itself so we actually end up in the basal LV. Up to 1 centimeter is acceptable. In this example here, we can work out how to determine regurgitant volume. Here we have our mitral annulus dimension of 3.5 centimeters. We've got mitral inflow VTI of 11.2 centimeters, an LVOT diameter of 2.0, and an LVOT VTI of 13.4 centimeters. So throwing all our numbers into our calculations, we know stroke volume is equal to the cross-sectional area times the VTI, breaking that down 0.785 times 3.5 squared times 11.2 will give us our stroke volume through the mitral valve of 108. Then doing the same for the LVOT, 0.785 times 2.0 squared times 13.4 gives our stroke volume through the LVOT of 42. It's simply a derivative of one minus the other, so regurgitant volume is equal to the incompetent valve minus the stroke volume through the competent valve. So regurgitant volume in this instance here is 66 mils. Note, in this particular calculation, all units in centimeters, so no conversions are actually acquired. Not only is the calculated regurgitant volume significant, but we also see changes with flow profiles. If we consider mitral regurgitation, the forward flow through the valve has increased intensity due to more blood cells creating a stronger Doppler shift. The maximum velocity flow through the valve will be increased, and the duration of flow may also increase. Then we can also consider the flow profile of the regurgitant jet. Is it signal as a similar intensity compared to the forward flow? Is there a rapid pressure equalization and a change to the shape of the profile? Is there also secondary reversory patterns that we can see in the pulmonary veins, in this instance for mitral regurgitation? Then we can also consider 2D findings, such as is the left atrium and the left ventricle dilated? Is the left ventricular systolic function hyperdynamic to compensate for the additional volume that must move forward? As most of this starts to deviate away from the hemodynamic principles, we'll actually revisit this later with valvular lesions in coming lectures. Our standard stroke volume assumptions apply. The hydraulic formula is based on a uniform volume of flow within the cylinder. The assumptions listed here must apply in this instance. These are that the cross-sectional area remains constant during the flow period, the cross-sectional area is circular in shape, the sample volume position remains unchanged in relation to the surrounding structures, and that the flow is steady through the cross-sectional area. As we explored earlier, we understand that flow profiles may change during the period of flow. The cross-sectional area may change in the period of systole or diastole, and this cross-sectional area is not always circular. Plus, the sample volume used to measure may actually move, or the heart may move while the sample volume is in a constant position. There is potential error in measuring the diameter, which is used to derive the cross-sectional area. A small under or overestimation can have a significant impact to the stroke volume result. The issue may be compounded as two sets of stroke volumes are calculated this way. In our example here, we can consider the mitral annular diameter of 4 centimeters. What if the actual diameter was 3.7 centimeters? And then we had our VTI of 11 centimeters. So 4 squared makes 16, therefore 0.75 4 squared times 11 equals 138. And then applying the same again, 0.785 times 3.7 squared times 11 is 118, and that's a difference of 20. So really quite significant, and especially if we're looking at actually small regurgitation volumes, we can actually have significant error. Prominent errors may also occur with the determination of the velocity time integral. An ultrasound beam that does not have parallel alignment with the flow underestimates true velocities of the flow. This can be observed by the image on the left. Notice how the Doppler cursor does not align well with the aorta. So here's our cursor, and there is aorta, and thus has poor alignment with the LVOT. The sample volume may be also positioned incorrectly, such as with the LVOT when it's too close to the aortic valve. There's systolic clicks and flow accelerations that occur as flow converges towards the orifice. Conversely, if it's too far away from the valve, we'll actually obtain LV systolic flow at the basal level. For the atrioventricular valve, some users inappropriately place the sample volume at the leaflet tips rather than the annulus. In this example here, both images depict appropriate placement of the sample volume. We can see closing clicks at the end of our profiles in the absence of any significant opening clicks. We typically see closing clicks because in systole, not only does the heart squeeze circumferentially, but can also shorten from base to apex. And so in doing so, we might actually have our aortic valve enter into our sample volume. Issues may also occur with the velocity time integral tracing. The user may poorly follow the edge. In most instances, we need to follow the modal velocity for pulse Doppler and the leading edge for continuous Doppler. The Doppler scale may be set too low, with flow extending off the screen, with some velocities lost or mingled with aliasing velocities in the other direction. Or it may be set too high with the scale, and very small representation of flow will be demonstrated on the spectral analysis, which is very difficult to accurately measure. The image on the left has many issues. The scale and baseline could be optimized by bringing the baseline up and dropping the scale. Gain is too low. It's impossible to define the actual flow profile itself. Given the following beat, it's unlikely that the modal velocity has also been traced, and what has been obtained appears to be a significant overestimate of the velocity time integral. And on the image on the right there, we've got aliasing and inappropriate scale settings. So we've got flow that's too large for the actual scale that we've got set, and we've got flow that's moving forward that's also mingling in with what we're seeing there. So it's actually very difficult to see where actually determine where the peak is, and to also determine where a velocity time integral should go. In the presence of rheumatic mitral stenosis with regurgitation or a carcinoid tricuspid valve, the stroke volume method for determining regurgitant volumes may not be accurate, as the effective orifice for the valve could be distorted. Consider a mitral valve in stenosis. How does it actually appear in systole? The forward stroke volume through another valve can also not leak. This is our competent valve. And in doing so, if the competent valve takes any regurgitation, the forward stroke volume through this valve is increased. Looking at a formula, it is seen this will lead to an underestimation of the regurgitant volume, and similarly, an intracardiac shunt will have the same effect. If the valve measured is distal to the shunt, and thus has a greater stroke forward volume, again the regurgitant volume calculated through this method will be underestimated. We must be aware that there is beat-to-beat variability. Even in someone with sinus rhythm has a slight deviation in heart rate and therefore stroke volumes with accordingly slightly different ventricular fillings. Multiple tracings are required. In someone with sinus arrhythmia, atrial fibrillation, or ventricular bigeminy, for example, then even greater numbers are required to derive a true representation of the average stroke volume. Finally, it must be noted, despite the best efforts of a sonographer, that even when we measure competent valves, that a regurgitant volume may be evident. Thus, when we do the grading of severity with our standard deviations, we use a 95% confidence interval set, and these minimize the possibility of a normal valve being classified as being anything other than actually mild. Regurgitant fractions are simply an expression as the percentage of the regurgitant volume compared to the normal forward stroke volume. This is represented as the equation here. So regurgitant fraction is equal to the regurgitant volume times 100, because we're expressing it as a percentage, divided by the stroke volume of the competent valve. Regurgitant orifice areas can also be calculated. Much in the same way that we determine the area of a stenotic valve, we can assess for the size of the leaking area. We have already described that the flow is equal to the cross-section area times by the velocity time integral. So substituting what we want to actually evaluate, regurgitant volume is also expressed as effective orifice area, substituting cross-section area, times the VTI of the regurgitant valve. And then changing around what we actually need. So we've actually got our effective orifice area, which is equal to the regurgitant volume divided by the velocity time integral. And here we have an example of a regurgitant fraction. So from our previous calculation, we worked out the regurgitant volume of the mitral valve was 66 mils. We know that the mitral valve stroke volume is 108 mils. So simply 66 times 100 divided by 108 gives us our number. So regurgitant fraction is 61%. Our effective orifice area is a manipulation of our stroke volume calculation, as we've just determined. So what we can do is we can then use our regurgitant volume of 66 mils and our velocity time integral to work out our effective regurgitant orifice area. So we've already mentioned that stroke volume is equal to cross-section area times VTI. All we're doing is substituting effective orifice area from the cross-sectional area and manipulating our formula. So cross-sectional area, or in our instance here, effective orifice area, moves over to the left side of our equation. So our regurgitant volume divided by the velocity time integral gives us our valve area of how big the hole is as the blood actually moves through it. And here we've got a table with a lot of numbers on there that gives us indications of severity. So in our top area here, we've got the mitral and tricuspid valves, and we can see the regurgitant volumes in our ranges here give us mild, moderate, moderately severe, and severe. We can also work with our regurgitant fractions, and specifically for the mitral valve, we can actually use the effective regurgitant orifice area again to determine how severe the valve actually is. Then below here we've got the same situation for our aortic valve. Note that the pulmonary valve doesn't have regurgitant volume ranges, and this is because there's significant variability in the data presented. Furthermore, pulmonary regurgitation plays little bearing in patient management, even when it's significant, and it's not often really assessed by regurgitant volume and regurgitant fractions. Note with the assumptions listed earlier, for the determination of stroke volumes, a regurgitant fraction compounds the potential problem by introducing the leaking valve stroke volume. Inappropriately measuring the mitral annulus in mitral regurgitation would lead to the error being presented twice. In summary, quantitative analysis for regurgitant valve plays an essential part of the standard echocardiogram. We should not rely on qualitative analysis alone. We've demonstrated how to determine the severity of valve lesions through regurgitant volume, regurgitant fractions, and via the effective orifice area methods. There are limitations and potential areas for the stroke volume method that have been explored here. And finally, there is another method that is frequently utilized in echo for regurgitation. This is PISA, or proximal isovelocity surface area method. And we'll actually discuss this one further in forthcoming lectures.